Hello, everyone. It's a great pleasure to present as a OCCN in KL this year. Let me share the title. So what I'm going to talk in this session is the EEG workshop. The title is the focal Epileptiform pattern, interictal, utility, and limitation. So let me introduction about the interictal spike. Interictal spike is remain the hallmark of epilepsy that demonstrate about the cortical hyperexcitability and hypersynchrony, and also can be present in normal interictal state. The presence of the interictal spike help to confirm the clinical diagnosis of epilepsy. It can be used as aid to defining epileptic syndrome and provide information assist in planning about the treatment with the anti-epileptic drug. Also can be helped to assess about candidacy for epilepsy surgery. So like all diagnostic tests, it has significant limitation and cannot substitute for a careful history and exercise of the good judgment. So interictal epileptiform discharge must be carefully distinguished from benign variants or normal brainwave to avoid overinterpretation of benign variants and artifacts. The common benign variants that could mimic epileptiform discharge, for example, like the small sharp spike of sleep, wicked spike, psychomotor variants, male rhythm, subclinical rhythmic electrographic discharge, or even though the artifact. So in addition, occasionally, some patients without the clinical seizure or epilepsy could be demonstrate epileptiform activity on interictal recording. Potential can be reading clinician to comment the AED therapy that may expose patients without actual clinical epileptic seizure, and also can be risk for the adverse effect from the medication. So the type, localization, and frequency of IED are of significant diagnostic and prognosis value in diagnosis of patient-specific epilepsy syndrome. For example, like the patient with the mesial temporal lobe epilepsy who consider for possible epilepsy surgery, who have the IED concordant to the surgical focus, have the superior operating outcome compared with those which have discordant bilateral temporal or extratemporal IED. So let me start with the focal reform pattern. The focal IED may occur over any lobe on either side, but most common seen in either temporal or frontal lobe epilepsy. Compared with the parietal occipital epilepsy, generally have a rarely activation of the IED. The IED on both invariable surface negative, localized by principle of electrophysiologic polarity. If we're looking about the montage, different montage, for example, in the left frame montage, the IED show the maximum negativity in channel having maximum amplitude. But if we're looking in the bipolar montage, the maximum negativity is at the side of the phase reversal. The characteristic morphology of the focal IED, very sharp right, complex waveform, often with solo phase or baseline crossing, and after going slow wave discharge, disturbing or disrupt about continuity of the blackout rhythm at read momentarily. So this example of the different montage on the left-hand side is the left frame montage. The IED show the maximum negativity in channel where having the maximum amplitude. If looking on the right-hand side, it's a bipolar montage. The IED show the maximum negativity is at the side of the phase reversal, like on the label, square label. So interictal scalp EEG in epilepsy, the EEG abnormal could be in the form of, one is the interictal epileptiform discharge, or could be the focal slowing, or could be the periodic lateralized epileptiform discharge, what we call the PLET, or could be the diffuse change such as frontal intermittent rhythmic delta activity. But only the IED and the PLET have a sufficiently high association with epilepsy. In focal epilepsy, interictal spike is guide for seizure focus, localization along with the clinical and imaging data. The pattern of interictal EEG assists in determining the seizure type. However, different EEG patterns have a different association with epilepsy, and therefore sensitivity and specificity of EEG pattern remain unclear. So the characteristic of the intermittent discharge could be the proximal with a spiky configuration standing out of the background, duration about 70 to 200 milliseconds for sharp wave, and 20 to 70 seconds for spike, abrupt change in the polarity, surface negative polarity, and have a field that we call the physiologic field. So this is an example, the picture of the interictal intermittent discharge. They show the outstanding with the sharp, with the field involving more than one electrode, and they show maximality on the specific electrode. So also the interictal scalp EEG in epilepsy can show focal slowing. For example, this in EEG in the epileptic patient, we show proximal focal slowing, this one on the left temporal area. Or the interictal scalp EEG epilepsy can show up the plate like the periodic lateral reform discharge. This like the periodic activity on the EEG. Although the EEG can be shown the intermittent rhythmic delta activity, this is one example of the EEG in epileptic patient. The interictal EEG can show the intermittent rhythmic delta activity that we call the FIRDA. Clinical information obtained by the interictal epileptiform discharge can use the diagnosis of epilepsy in proximal event, can use the identification of refractory epilepsy, and also can use as predict of the seizure recurrence after the single unprovoked seizure, or use the diagnosis of epileptic syndrome and predicting prognosis. Can use the identifying surgical remedy epilepsy, or we can be used at the probability of the seizure recurrence after we plan to medication withdrawal or medication withdrawal following after the epilepsy surgery. So the example of we use EEG, the interictal epileptic discharge, diagnosis of epileptic syndrome. So this a young boy who have the clinical seizure and the EEG show the proximal ictal spine wave on the occipital area, and this boy have a benign occipital epilepsy. Or the interictal platform discharge can diagnosis of some epileptic syndrome, like the example of the EEG in 5-year-old boy who have a Landau-Kleffner syndrome during awake. They show look like the normal EEG, no epileptiform discharge. And during the non-REM sleep, they show the electrical status epileptiform discharge that come during the non-REM sleep. It's on show up on the EEG on this side, on the right side. So also we use the specificity, how about the specificity of the interictal epileptiform discharge. IED are really uncommon in people without epilepsy. There is a study have reported IED found in about 0.5% in adults and 1.9 to 3.5% of the normal children without epilepsy. However, about 2.5% can be develop epilepsy later within 10 years. Approximately about 5 times of the population list. Incidental epileptiform discharge occurs slightly more often. 2% in subject with history of the previous neurological insult. For example, in patients with traumatic brain injury, stroke, patient who have a craniectomy before, infection, cerebral palsy, or even though the migraine, headache, up to 40% of these patients subsequent can be developed seizure. So in children without the prior seizure, epileptiform discharge may occur in about up to 5%, and this may be at high at 8% if adequate sleep is recording. So they tend to be benign Rolandic occipital spike, or even though the July 3 Hz spike discharge, and rightly they represent about incidental genetic trait. Rate of subsequent seizure in this seizure group is about 6%. So how about the utility of the EEG in the diagnosis of epilepsy? One is we're looking about the sensitivity of the interictal EEG recording. How often the EEG detect interictal spike or sharp wave in people with epilepsy? Methodological difficulty place limitation interpreting study that answer the question. Epilepsy often a clinical diagnosis, which may be inaccurate even in the experienced hand. The interictal EEG finding may have influenced physician diagnosis of epilepsy, which could introduce bias in assessing about the sensitivity of the test. So EEG could direct toward particularly type epilepsy and help distinguishing several possible syndrome in complex and confusing clinical situation. However, critical analysis of the sensitivity, specificity, and positive predictive value of different EEG features is not possible. There are 3 lab studies of mainly adult patients reporting about range of the sensitivity of EEG in detecting IED. The initial EEG is positive for Epileptiform discharge, allow 29 to 55% being more sensitive in generalized epilepsy. Repeat EEG and longer duration of recording might be more useful, increase the yield up to 80 to 90%. EEG is a persistent negative. It can be found about 8% of the patient with epilepsy, and higher proportion of these patients have a partial seizure, still have a negative interictal EEG. So that EEG had a lower yield, estimate between 12 to 50% in patients who have only 1 seizure, or those who well controlled and would undergo medication withdrawal. That's really, we have to be really careful when we do EEG, even though the normal, and when we try to reduce the medication. Interictal EEG have a variable sensitivity and the yield depend upon a number of factors. So now we can use something like the automatic detection methods, have a great assistance in spike detection during the long-term monitor of epileptic patient. Conditions that increase the yield of EEG detect interictal epileptiform discharge. One is in children group and seizure start in early life. Or we're doing the EEG within 28 hours after the seizure. Some certain epileptic syndrome, such as benign Lowlandic Lennox-Gastaut syndrome and Landau-Klempner syndrome, can be easy to find the interictal discharge. And the patient will have a greater seizure frequency, also increase the yield to detect IED. Sleep and sleep deprivation, that's very common. Sometimes we do sleep deprivation or sleep EEG to get more yield to detect IED. Or even though we have to do the serial EEG, like do EEG at the serial, maybe the second or maybe third EEG, if we still cannot find the IED and the clinical still suspect epilepsy. Several methods have improved chance of detecting IED in the EEG, that including sleep deprivation, hyperventilation, Photic stimulation, or maybe employing additional electrode. Serial EEG, that's we're doing commonly in clinical practice, or even do a 24-hour EEG if you have a facility to do EEG study in your clinic or in your hospital. Sleep EEG, sleep efficacy improve about detection of focal IED. In the substantial minority of patients with focal impaired awareness seizure, IED are found mostly during sleep. Recording during wakefulness, sometimes you might be faced with the contaminated by the muscle and the movement artifact. The EEG recording during sleep, we demonstrate IED in approximately 40% of epileptic patients in whom no IED was seen during wakefulness. Sleep deprivation for 24 hours increase the yield of IED by 20% or more. So hyperventilation and Photic stimulation might be useful, increase the generalized spine wave in about 50 to 80% of the patient. But for the focal epilepsy, like to take the focal spike, is less impressive. Hyperventilation activates focal IED only 6% of the case only with the focal impaired awareness seizure. And the clinical seizure is in over 4% of the case. Overall, hyperventilation increases the yield of the focal IED less than % of the patient. How about the photic stimulation? It's induced IED in many patients with epilepsy, and occasionally in individuals without a history of epilepsy. It usually signifies particularly the IgE, childhood absence, juvenile absence epilepsy, or even the JME with juvenile mild epilepsy. In patients with a partial seizure, photic stimulation may trigger epileptiform discharge when the seizure emanates from the occipital lobe. Additional electrode might be needed. You have to need to placing additional electrode may be held to detect IED, particularly when the epileptic discharge comes from the temporal lobe. Anterior temporal electrode and other inferior place of the skull electrode and the sphenoid electrode are better placed to detect the inferior direct dipole and actually offer advantage. Temporal IED capture with different electrode. For example, light IED record about 43 to 58% of patients with standard electrode array, but when we use a special electrode to cover the temporal lobe, it can be up to 81 to 90% with the true anterior temporal electrode. And if you use a sphenoid, you might be yield increase the detect IED about 75 to 100% of the case who have a temporal IED come from the temporal or mesial temporal area. Even though the silent hippocampal seizure and spike that have been found more common in the Alzheimer's dementia can be identified by using special electrode by the foramen ovary electrode. Extra electrode rarely needs for routine diagnosis purpose, being mainly helpful when evaluating patients with epilepsy surgery, but some cases might be need special electrode. For example, like I say, in a patient with dementia, Alzheimer's dementia, sometimes you need to put more special electrode to detect about the IED come from the mesial part of the temporal area. How about the epileptiform discharge in the first and serial study? The first standard EEG in patients with diagnosed seizure disorder contain epileptiform discharge approximately about 50%. Apart from sleep, several other factors show the increased likelihood of the epileptiform discharge, including recording about 48 hours after the seizure, or maybe ongoing seizure frequency at least one attack per month. Serial EEG often necessary for demonstrate epileptiform discharge. Most patients will eventually show epileptiform discharge by the first EEG. The ideal time for obtaining an EEG in the first day or two after the seizure. Also, you should consider the long-term monitor if full routine EEG recording have remained negative in patients with ongoing seizure. So the specific of the interictal epileptiform discharge, spike location, and probability of epilepsy. The probability that IED indicate epilepsy relate to the location of the discharge as well. Only about 40% of individuals with a central mid-temporal spike and 50% of those with the occipital spike have a seizure. So these show that the spike location and probability of the epilepsy. The high probability of the epilepsy, more than 85%, if you found IED located on the anterior temporal spike, mid-temporal spike, vertex spike, hip rhythmia, slow spike wave, generalized proximal fast activity, and the moderate probability of epilepsy less than 25% in when you found the frontal spike, generalized spine wave, central occipital spike, and photoproximal response. The EEG recording patient with metabolic encephalopathy sometimes can be revealed, occasionally reveal IED, focal and multifocal spike, and diffuse spike and sharp wave reporting in dilated dementia, hypoglycemia, rhythmic encephalopathy, eclampsia, thyrotoxicosis, and Hashimoto encephalitis. Epileptiform activity can be associated with the diffuse slowing in patients with the hypoglycemia. In non-ketotic hyperglycemia, like the PLEP, can occur with the partial seizure. Certain medication also sometimes can produce IED, including the copomazine, lithium, clozapine, especially at high doses. So IED occasionally seen in patients with a mad lesion, such as the abscess, intercerebral abscess, or slow-growing tumor without any history of the seizure before. However, you need to monitor this case carefully because the indicate might be have a high risk of the subsequent development of the seizure later on. So how about the role of the EEG diagnosis? So EEG important tool for diagnosis epileptic syndrome, aid in the planning treatment and determining of the prognosis. And present of the focal IED suggest the diagnosis of the focal epilepsy. Character and location of the focal IED offer clue to both etiology of epilepsy syndrome and location of the epileptogenic lesion. Focal blackout slowing suggests diagnosis of the symptomatic epilepsy, and persistence of the attenuation of the blackout rhythm or continuously polymorphic delta activity suggests the presence of the structural lesion. Occasionally, interictal spike can be misleading, for example, like the generalized spike discharge seen in 7% with the benign low-land epilepsy. Therefore, EEG must always be put into context with the history, physical examination, and neuroimaging finding to ensure a proper diagnosis. This go to example of the some type of seizure, low of the EEG diagnosis. For example, like the staring spell, a common presentation in children with different kind of epilepsy can be manifestation of childhood absence, atypical absence, Lennox-Gastaut syndrome, or focal impaired awareness seizure. So EEG can help to differentiate among these syndromes. If the patient comes with the generalized tonic-clonic seizure, occasionally differentiating between the generalized epilepsy and focal epilepsy is problematic, particularly secondly bilateral synchrony discharge. Secondary bilateral synchrony are present of frequent IED occurring repetitively in the localized area, differ from generalized IED because the focal IED clearly and consistent precedes or initial generalized IED. For the patient who have a nocturnal seizure, some children may have episodes of during facial twitching and unresponsive at night, suggestive diagnosis benign low-land epilepsy or temporal epilepsy. EEG is helpful, present of sensotemporal spike, suggestive of benign low-land epilepsy. Law of interictal EEG in evaluating patients for epilepsy surgery, the location of the interictal spike often correspond to region that should be resected to confirm by other tests. Clear laterality of the spike in patients with temporal epilepsy provide the reliable guide for epilepsy surgery. About the role of the interictal EEG in evaluating patients for epilepsy surgery. In patients for evaluating for epilepsy surgery, more than 25% have independent bitemporal IED. However, with intracranial EEG, 73 to 83% of these patients have the seizure emerging from only single temporal lobe. So presence of bilateral spike does not preclude a unilateral seizure source. Interictal EEG less useful in localized in extratemporal epilepsy. Many patients with frontal lobe do not have IED. Mesial frontal, orbital frontal surface not accessible to the scalp recording. In parietal lobe epilepsy, IED localized to parietal region less than 50%. How about the predicting of the recurrence after the single seizure? Prediction of the recurrence after the single seizure in clinical is very important. However, different in methodology make comparison of this study difficult and results still remain controversial. A meta-analysis of 16 publishing reported suggest EEG abnormality may increase the risk of the recurrent seizure after the first seizure. So the interictal EEG is helpful to assessing about risk of recurrent seizure. Presence of the EEG abnormal associated with the heightened risk of the seizure recurrence. The role of the EEG in predicting relapse after the AD withdrawal also remains more controversial. The existence of the EEG abnormal indicates the increase of the risk of the seizure recurrence. In one study, only generalized IED in patients with tonic-clonic seizure indicate an increase of the risk for relapsing significantly. In another study, focal non-preform abnormal or non-prefix diffuse abnormal did not predict about the increase of the risk. However, one study found either focal or diffuse slowing IED show improvement of the ED associated with the relapse. So nonetheless, EEG far from perfect, offer information that may be used in arriving at a decision to discontinuation of medication. So you have to do together, use the clinical information together with EEG. That might be useful. So in conclusion, The interictal EEG provide information that aid in diagnosis and management of focal epilepsy. Presence of the interictal spike help to confirm clinical diagnosis of epilepsy. It can be used aid in defining epileptic syndrome, providing information that assists in planning drug management. It can use to help to assess about candidacy for epilepsy surgery. However, EEG is merely a tool, and its usefulness depends on largely upon the skill of individually who use it. And this is also the final take-home message. It's like all diagnostic tests, it has significant limitation and cannot substitute about the clinical history. It has to be used together with the clinical information, and we can use EEG at the end to confirm the diagnosis. That is my end of my talk. Thank you very much for your attention. Thank you very much.